this kind of, brings me to another layer of discussion, which is, if anything, where can we, if you recall, we spoke about the different layers of the BCLC, we spoke about the horizontal connection between the different lines of therapy, but always there was this kind of collusion, which I spoke about in the beginning, is can we make more BCLC patients who are eligible for local therapy get more systemic therapy, or can we make BCLC patients get for more local therapy rather than the systemic? And if anything, I recall that I spoke about that almost 10 plus years ago in an editorial in JCO, and I said it's more a marriage than a divorce. And talk about that marriage. Can you please tell us, Catherine, about what's going on in the world of yttrium-90 plus systemic therapy?
So, looking at the Y90 data that's out there, right now the guidelines say, there isn't a big randomized phase 3 controlled trial of Y90 trying to exactly figure out where it fits into the landscape of HCC treatment. We all know that there's response. There's been 2 large studies just recently presented looking at Y90 versus sorafenib, which really resulted in equivalent overall survival, although of course Y90 has less side effects for that duration. There are several studies going on with combination of Y90 with sorafenib. We know that sorafenib has also been studied with chemoembolization, although some of those trials are very difficult to complete and interpret. So I think that combining systemic therapies with some of our local regional therapies, or potentially even getting back into the adjuvant and neoadjuvant around resection, which sorafenib didn't pan out with, but maybe one of these other TKIs will. I think there's a lot of exciting studies that need to happen in HCC to really answer some of these questions.
I'm glad you bring this up in regard to the SOMIC study, which is yttrium-90 plus sorafenib. And this really, actually, Catherine already suggested that. But can you tell us more, Ruth, about the story with the TACE plus sorafenib?
So there are 2 randomized studies have evaluated the combination of TACE plus sorafenib, and those studies turned out to be negative. I think it's very difficult. It's a sort of difficult study design because it's difficult to control how TACE is giving, how much TACE, how many, the vessel distribution when the TACE treatment is delivered, and also the interventional radiologist's expertise in how to give in TACE treatment. So it's very difficult to design the study. The conclusion from those studies is the combination has not generated better results.
No, totally agree. If anything, the space study that was done by Dr. Lencioni was negative. Add to this, the TACE2 study from the UK was negative, and we still have one more study to be reported, which is ECOG 1208. And if anything, you're right, there's a big concern about if the activation of the tumor after the TACE is really to be governed only or controlled by a TKI, or could be a role for something else. And that something else brings me back to Anthony in regard to the combination of TACE plus a checkpoint inhibitor.
So before I answer that, can I nuance the Y90 story from my perspective? I think the challenge we have with Y90, with the 2 trials that Catherine mentioned, which were randomized studies of Y90 versus systemic therapy, is that those studies were designed actually as superiority trials. Mm-hmm. And so by definition, they were actually negative studies. So we cannot say that the survival was equivalent. It was numerically in the same range, but they were not non-inferiority studies to say those therapies are equal in those patients. So
good point.
I think our understanding again of where to fit Y90 still has to evolve a bit more. Going back to your question, so combining locoregional therapy with immunotherapy is something that's gaining traction now with many trials, a lot of investigator-type initiated trials that are evolving. I think there's a strong rationale for it. Briefly, in a simplified fashion, that is the rationale that the local ablative therapy, whether it's chemoembolization, Y90, or or ablation can increase antigen release and stimulate the immune system even further and complement the anti-PD-1 targeting strategy. We will see if that pans out. So far from the early data that we've seen from Tim Gretton at the NCI, where he combined tremelimumab, an anti-CTLA-4 antibody, with some ablative therapy, that it's feasible. But we don't have outcome data yet. But certainly this will be something that we will see a lot of over the next few years.
Absolutely, absolutely. If anything, there is a clinical trial that's currently ongoing of TACE plus nivolumab that we'll see where it's going to take us in regard to the safety and the practicality of that combination. But also in addition to that, there are other aspects of therapies that we not necessarily did touch on, but also talk about combination, among which the vaccinia virus with GX594, which is a tyrosine kinase, which is altered, that's given as intratumoral injection, in addition to giving sorafenib on board, which is a Pexavac study, which is still ongoing. So there's plenty going on in that field, and as we just heard from all of us in regard to the combination of local plus systemic therapy.